Okay, now we're going to transition a little bit and start talking about cardiac disease. And we are going to talk about hypertension, which most of us are very familiar with in this point of our career. But let's just do a quick refresher. So we know hypertension is elevated blood pressure, systolic and diastolic. Textbook norm is 120 over 80. But how do we diagnose hypertension? The answer to that is getting a blood pressure. But we need to take it at least in two different occasions where the blood pressure is over the norm. And the most accurate method of confirming an elevation in blood pressure or hypertension is by taking an ambulatory blood pressure, or some people would say at home blood pressure monitoring, because there is a phenomenon called, you said white coat syndrome, you're correct, where patients come in and they just have elevation. They are a little nervous. They are at the doctor's office, or they're seeing their NP or PA and they feel uncomfortable. Maybe they've rushed to clinic. Um, Lots of different reasons. But to be accurate, we send them home with at-home monitoring blood pressure devices to capture what their overall trend is throughout different points of the day. And this is more accurate. We need at least two elevations of blood pressure to diagnose with hypertension. And I'm going to encourage you to look at the difference between prehypertension and true hypertension, and know what those cutoff points are. So, if you have a patient with hypertension, according to the JNC8, what are the first line therapies for hypertension? For most patients, widely, thiazide diuretics are going to be your first line treatment. Usually, if thiazide diuretics are not working or contraindicated, then we move on to angiotensin converting enzyme inhibitors or ACE inhibitors, or you might try an ARB or an angiotensin 2 receptor blocker. In some cases, you may need to try a calcium channel blocker. Now, if you're saying, well, what about beta blockers? When are they indicated? For hypertension specifically, we would consider a beta blocker if our patient also has heart failure with reduced ejection fraction, or perhaps they are post myocardial infarction or heart attack. They experienced angina as well. They have atrial fibrillation requiring um, help with monitoring, or not monitoring, but helping to sustain a certain heart rate. They would be a candidate for beta blockers. Or if they already have chronic kidney disease with proteinuria, then I would march over to the beta blocker above the other types of drugs. If you're unclear about the JNC8, I would go and look that up immediately to help with your hypertension management of all patients. Also, it'll show you the cutoffs too of the different stages of hypertension. So let's consider for a second though. We've talked about these different medications, but let's recall the different side effects for the thiazide diuretics, ACE inhibitors, ARBs, calcium channel blockers, and beta blockers. So starting with the thiazide diuretics, what are some common side effects that you can think about or that come to your mind? Because it's a diuretic, thiazides actually can cause hypokalemia, a reduction in your potassium, a reduction in your sodium, so hyponatremia, as well as hyperglycemia, or an elevation in blood glucose. ACE inhibitors, the most common side effect that patients report are cough, but also it can do the opposite to your potassium that thiazide diuretics do. It can also cause hyperkalemia. Another side effect would be angioedema. For ARBs, just like ACE inhibitors, we might have hyperkalemia. And Patients on any type of antihypertensive medication are subject to dizziness and hypotension, but most reports will show that ARBs have a little bit higher profile for dizziness and hypotension. And often you want to monitor for first dose hypotension for any of these patients to see how their body is adjusting to their dosage. Now, with calcium channel blockers, peripheral edema tends to be an issue, constipation, as well as dizziness. And lastly, with jumping the gun here, with beta blockers, you might have bradycardia. You might have fatigue, depression, even, and beta blockers can also cause sexual dysfunction. I'm going to create another video talking about ischemic heart disease a little bit and also the clinical manifestations of acute coronary syndrome.